we are still on the subject of headache, and we are looking at one enabling objective. You have to look for signs and symptoms to differentiate between or among the various causes of headaches. So that's where we are moving towards. We've looked at the history. We've looked at some of the red flag signs. We've looked at physical exam. Now we are going to look at signs and symptoms to differentiate among the various causes of headaches. Beautiful. So we said that, we can have some benign cause of headache. And I'm going to let us take our time to evaluate this. So the benign cause of headaches, we have tension headache, migraine headache, and cluster headache. So if you have a question stem, how do you determine whether this patient's headache is tension, migraine, or cluster? Number one, typically patients with tension headache, they don't have a family history. Migraine headache, the patient will say, my sister has it, my mother has it, my brother has it, strong family history. Cluster headache, they may, but it's not so strong. So number two, location. Tension headache is usually bilateral and it's frontal. And it can also have nuchal and occipital, that is on the back. Migraine headache, most of the time, it is unilateral, more than bilateral. Migraine headaches mostly occur unilaterally. Cluster headache, it is retroorbital around the eye, supraorbital here, and temporal. So always look at the way your question stem is being designed. That is what will help you to know, okay, is this cluster, is this tension, is it migraine? Now, how long does the headache last? If the headache lasts minutes to days, you're thinking about tension headache. If it lasts hours to days, you're thinking about migraine. If it lasts 10 minutes to 2 hours, you're thinking about cluster headaches. And then the quality. If you have band-like headache, if I describe in your case that the patient has band-like headache, which is constant, band, think about tension. Okay? And if I say, oh, the patient's headache started just a few days after she got a new boss, think about tension headache as well. Because tension headache occurs with depression, anxiety, noise, hunger, sleep deprivation. So it could be that new boss is a trigger to the patient's concerns. Then you know that there's a problem. And then migraine headache, it's triggered by noise, light, caffeine, alcohol, sleep. And then cluster headache, associated with light and alcohol. And associated symptoms, tension headache, usually no vomiting, no photophobia. Migraine headache, and I see them a lot in the emergency room. After this class, I'm going to the emergency room to work. You realize that a lot of them, they come in and they want you to put off the lights in the room because the headache is too much, right? They may have phonophobia, they may have an aura. And then cluster headache, they may have red, watery eye, eyelid, forehead swelling, nasal congestion. So doctors, I'm going to do some permutation. This one, I don't want you to shout the answer. I just want you to type your answer for me. So you have a 38-year-old lady. She works as a secretary in a law firm. The owner of the law firm has died and a new partner has bought the law firm. And he's had the law firm for just about 2 months. And this lady comes to you saying that, look, doctor, I'm having severe headache. This headache, when it comes, it lasts for about 20 minutes. Usually, it is bilateral. And you ask, do you have vomiting? The patient says no. Do you have photophobia? The patient says no. Doctors, what is your topmost diagnosis? Please type your answer. Type your answer. Type your answer. Beautiful. Tension, 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 tension. Okay, good. So I have another patient who says that, doctor, I have this headache. In fact, when it comes, I can't look at light at all. My mother also has a headache. And when it comes, usually it's on the right side of my head.
Migraine.
Just stop typing.
Doctors, look, the MCC objectives can be made simple. Please, are we simplifying everything for you? Hello? By the way, okay, I want some feedback. I want verbal feedback. I want somebody to give me some feedback before we continue. Because, these things, migraine, tension, and cluster headaches, they usually confuse a lot of candidates. What is your feedback so far? Approach to headache.
Yes, you're doing great.
Since I'm doing great. Sure. What
More
else?
than it.
Yeah. So, we are taking our time to really break it down, and that makes things very good. Okay. So now you know that in your MCC objectives, usually you have to also know the management. So tension headache, how are you going to manage the patient? Because it's this patient who has a new boss. You can't take medications to clear that away alone. So they'll also need some psychological counseling if it's coming from anxiety, right? Some physical modalities like heat, massage, and some pharmacological medications like simple analgesics, Tylenol, Advil, tricyclic antidepressants. For migraine headache, you have to learn, please write this down. Please write this down. You have to learn how to manage migraines acutely, and then the prophylaxis we can give for migraines. What are the medications we can give for migraine acutely? And NSAIDs like Aleve, Advil, you know, um, aspirin, that's ASA, triptans, ergotamine, valproate, antiemetics like metoclopramide and lidocaine. And then the medications we can give for migraine prophylaxis are tricyclic antidepressants, anticonvulsants, beta blockers, and propranolol. All right. And then cluster headaches, you can manage it with oxygen, sumatriptan, and the sumatriptan can come as a nasal medication or injection. Prophylaxis for cluster headache can be verapamil, lithium, metacegid, prednisolone, and valproate. So please, when you get a replay, take your time and make sure that you've mapped out the management of acute migraine, the management of the prophylaxis for migraine headaches as well. Okay. Yeah. So one other thing, especially because the medical council is moving towards MCQs alone next year, 2025. So those who plan on writing the exam next year, please remember that from next year, April, there's no going to be any CDM portion. The commonest cause of headache is tension headache. Don't get that wrong. Commonest cause of headache, tension headache. Even though migraine headache is common, but the commonest type of headache is tension headache. The differentials of different type of headaches: migraine headache, cluster headache, giant cell arteritis, pseudotumor cerebral. Remember, whenever this one, I'll even say that I should change the way I've arranged them. If you are listing differentials, always list that differential which can kill the patient first. All right. So giant cell arteritis, meningitis should come first for migraine and cluster headaches. So now let's take our time and take those headaches one by one. So what did we say? We said that cluster headache can cause swelling of the eyelid, in the front of the head. So whenever you are thinking about headache, look at this man's face very well. Picture his face in your brain so that in your exam, you will know how cluster headache will present. They may sweat, they may have swelling, they may have tearing, they may have running nose. I have a question. Cluster headache and migraine headache, which has stronger family history? Cluster headache or migraine headache?
Migraine.
Beautiful, beautiful, beautiful. How will cluster headache present? Frequent and short duration, high intensity episodic headaches. Men are affected more than women. Men are affected more than women. Men are affected more than women. Usually it is unilateral and periorbital, and the patient may have stuffiness around the nose and lip pulses. Okay. Physical exam, the patient will present with red eye, tearing of the eye. They may have rhinorrhea. They may have Horner sign. That is, some unilateral, like they may have anhidrosis, like no sweating on that part of the face. They may have ptosis as well, and they may have headache. Okay. Management of cluster headaches, we've already talked about it. There's no diagnostic test you have to do. You have to just listen to the history and put two and two together, right? 100% oxygen, ergotamine, prednisolone, lithium is also very effective. How do you give prophylaxis? Verapamil, prednisolone, and sodium valproate. So please learn the management of acute cluster headache, learn prophylaxis for cluster headaches as well. Migraine headache, we said that it is usually unilateral, strong family history, photophobia. I'm just going through them because we've already used that table to get it going first. Okay, non-specific findings. Do we have to do any investigations? No. How do we treat migraine headaches for them to go? We can use triptans or ergotamine. What you have to know is that in migraine headache, oxygen, prednisone, and lithium are not effective for killing the migraine headache off. No, they are not effective. And what are the medications we can give for prophylaxis? Propranolol. But if you give propranolol, what is one thing you can tell the patient? If you give propranolol, what is one side effect you should tell the patient? Propranolol. What side effect?
Libido.
Tachycardia.
Hypotension, and libido.
Bradycardia.
Hypotension, bradycardia. Hypotension, bradycardia. Hypotension, bradycardia. I heard somebody say decreased libido. Yes, maybe decreased libido, but when you are also listing like side effects, also think about side effects which can kill the patient first, right? Before you even go into any other thing. Hypotension, bradycardia. Calcium channel blockers can also be used. Tricyclic antidepressants like amitriptyline, SSRIs, and topiramate can all be used. Tension headache, we said it's usually bilateral. Periods of anxiety, periods of depression, a newborn, a marriage where the patient is going through so much. Tension headache, right? Bilateral, band-like. It will last for about 4 to 6 hours. Physical exam, the patient may be normal. Management, we said you want to use psychological treatment if it is because of anxiety. And you can give you a simple analgesics like NSAIDs and acetaminophen. Now, one other cause of headache I want us to look at briefly tonight is medication overuse headache. Medication overuse headache. Medication overuse headache. Medication overuse headache. Medication overuse headache, look out for that patient who has been taking like opioids or NSAIDs like for a very long time. And they'll present bilateral band-like muscle contraction and tenderness. And they may have photosensitivity. And it is almost there almost every day. And the management for that is that you discontinue the medication, and you can use triptans or ergotamine during the time you are withdrawing the medication. So please, that is also something you need to know. Medication overuse headache. Medication overuse headache. Now, other things I want you to know, pseudotumor cerebri. Pseudotumor cerebri. Very quick one. How the patient with pseudotumor cerebri presents. They may present with papilledema and diplopia, double vision. Papilledema, diplopia. So you have a patient, you check the eye, boom, looks like flame, angry at the back of the eye, and the patient has sixth cranial nerve palsy. Think about pseudotumor cerebri. How will you investigate a patient with pseudotumor cerebri? You can do CT or MRI to exclude any intracranial mass. And you realize that the CT may be normal. You may not really see so much. It may be normal. Okay. But then how you pick it up is when you do a lumbar puncture. When you do a lumbar puncture, you realize that the opening pressure is high, but the cerebrospinal fluid itself is normal. The CSF pressure is high, but the cerebrospinal fluid itself is normal. How are you going to manage a patient with pseudotumor cerebri? Weight loss, acetazolamide, and acetazolamide so that it can decrease the production of the CSF. Steroids, okay? And a repeated lumbar puncture rapidly lowers intracranial pressure. So you want to, at times, repeat the lumbar puncture so that the pressure in the brain will go down. And you can place a ventriculoperitoneal shunt into the area so that it can help to drain the whole thing. Now, other serious causes of headaches and how to distinguish them. Because you know that here we don't just do regular reading of a textbook, and some people say that there are 10 classes where they read textbooks to them. No, that's not what we do here. We want to get pattern recognition. Okay, so let's start. The serious types of headaches, we've already looked at them, but we're just going to use this as a revision. Usually, meningeal irritation, so you're looking at meningitis and encephalitis. It can happen at any age. It can happen to children. It can happen to adults. And the onset, hours to days. Subarachnoid hemorrhage may have thunderclap onset, right? What are the things which provoke it when the patient moves the head? What are the actual symptoms of meningeal irritation like meningitis? They have neck stiffness, they may have photophobia, they can have focal deficits, cranial nerve palsies, Koenig's positive sign, Brudzinski positive sign, and they may have meningismus. What investigations would you request for? CT of the head, MRI of the head. But before you do that, before you send the patient out, so far as you suspect meningitis, please don't forget to give your antibiotics. Don't forget to give your antibiotics. And the two causes of meningeal irritation as meningitis, subarachnoid hemorrhage. What about raised intracranial pressure? It can also happen to anyone at any age. Usually it is gradual because if it's a tumor or something, it is gradual. And it is worse when the patient lies down. If the patient lies down, it is worse. If the patient also goes to any Valsalva maneuver, it is worse. If the patient's head is low, it is worse. If the patient exerts himself or herself, it is worse. There is associated nausea and vomiting. There can be focal neurologic symptoms. There can be decreased level of consciousness, focal neurologic symptoms, and papilledema. You can also do a CT and MRI of the head and treatment to reduce pressure. So raised intracranial pressure, depending on what is causing it. If it's a tumor, that tumor may have to be dealt with either by surgery or by, any other means like surgery, radiation, if it's malignant and they can't take it out. And in temporal arthritis, we've already learned about it. Usually it is in older people, right? More than 60 years of age. Tenderness on the temporal region. It is variable in its onset and presentation. The patient may have jaw claudication. The patient may have proximal muscle weakness. The patient may even have non-specific weight loss. I have a question. What condition is also associated with temporal arthritis? What condition?
Polymyalgia or
PMR. And how would you manage the patient with temporal arthritis? Prednisone. It's a
High dose of steroids.
Yes. Okay.